Yeah.
Thanks, Peter.
Okay. Katja, whenever you're ready.
Yeah, I'll just find the slides.
I can't share.
Let me make you co-host as well.
Oh, that might be cool.
Yeah. Hi, John.
With mum today, just because, you know, nice to have a bit of a change. So yeah, the first one I'll be doing is being ill, and then Peter will take over. Pretty much this entire area is unfortunately kind of low yield, except for that third dot point. Comprehend the sick rule and the limitations of this concept. And that one's pretty important, it comes up on most exams. And the other three like may come up, but generally not likely. So the first one, help-seeking behavior, is just an adaptive coping process that is the attempt to obtain external assistance to deal with a health concern. The only reason we're talking about health-seeking behavior is we also talk about delayed behavior, and we want to figure out why do people not come to the doctors when they first find out they're sick. So people tend to seek help if the disease is like really visible, like if you have like a huge, like a skin rash, that's like massive and it's like, you know, inflamed. You're more likely to go to the doctor to get it dealt with than if something that like perhaps is less visible. Painful, of course, disruptive if you can't go to work, frequent and persistent if it's novel, if it's new for you, and then the ones that are specifically highlighted in your lectures is if it's perceived as serious or if you have a family history of it. So remember those two. So yeah, illness delay when they, the time between when they actually feel sick versus when they seek help. It's usually because of a variety of reasons, specifically emotional response is huge. People tend to be worried when they find out they're sick, anxious about what it could mean. And it's this whole idea that if you don't see someone about it, it doesn't exist. So you're like, oh, I might have like symptoms of like, let's say breast cancer, but you don't want anyone to confirm it. So it might be like a purposeful decision not to go to get checked out because you're too scared about what the answer might be. Other reasons include embarrassment or stigma, financial strains, lack of money, lack of perceived benefits from treatment. So this is specifically for like a chronic illness. Like if you have chronic neck pain for the last 3-4 years, you might see there's no point going to the GP about it again because there seems to be nothing new in the market to help you treat it. And an illusion of invulnerability, which is mostly commonly seen in adolescents, where it's like nothing can go wrong with you because they're supposed to be young and healthy, apparently. The next one, this is like the stages of illness. Pretty much there are 4 stages. First is that uncertainty. Second is your disruption of daily activities. Third is when you try to recover. And fourth is restoration of well-being. And there's an example down there how it would kind of work for the diagnosis of cancer. So like the uncertainty is like your initial response. It's your shock, your denial, your anger. And then disruption to daily activities, you might have, might be in a bad mood, might have poor sleep, reduced appetite, anxiety. And then when you're striving for recovery, you adapt. So you start doing things that tend to make the cancer either better or the effects of the cancer better. And then fourth, the restoration of well-being. So here, there's no like full recovery necessarily from diagnosis of cancer, but it means like well-being in terms of you're returning to like a new normal. This dot point is sort of just talking about the impact of illness. So in like recent years, I want to say in the last 20 or 30 years, the idea of quality of life has become a lot more significant. And like the aesthetic as well view of things. Because before when they were treating people, they wouldn't really care necessarily about the quality of life after the treatment or about how the treatment looks. Whereas now they take a lot more care into making sure that the person feels comfortable. Let's say they had surgery to make sure the person feels comfortable returning to normal activities. Like they're not embarrassed about the surgery, like marks, for instance. And the World Health Organization has developed like a list of criteria to measure quality of life. And there are in those 6 areas on the left. So physical health, psychological independence, social relationships, environment, spirituality, religion, and personal beliefs. And on the right of the screen, you can see the list of like questions that you generally ask to assess one of those areas. Now, this one is the high yield one. So if you've zoned out, zone back in now. This is all about Parsons' sick rule, and pretty much it has 4 like things that that you do when you're sick. 2 of them are rights and 2 of them are obligations. So if you're sick, according to Parson, you should be excused from normal roles and responsibilities because you're like impaired. So that's like a right. You have the right not to work. The second sort of part of the sick rule is that generally Parson considers you to be sick and have this position if you're not personally responsible for being sick. So for instance, if you're sick because you ate like too many bananas, Parson didn't consider that to be like a true sickness. You have to like not be at least fully responsible for your sickness. And then you have 2 obligations when you're sick. The first is you have to want to get better. So Parsons like, you're not truly sick, or he doesn't think you like use the sick rule properly if you're not trying to get better. And finally, you have to seek assistance, whether that's going to the doctor or going to the hospital, or going to like a mental health practitioner. You have to seek help from someone who knows better than you. So know those 4, they do come up in assessments from time to time. Some limitations is that sometimes even when you're sick, according to Parsons, you shouldn't work, but sometimes you just have to work, right? Like we have jobs, maybe you have to make the money. You don't have a choice to stay home. Also, there are sickness where you are kind of responsible, but like it's not necessarily entirely your fault. So like let's say you're sick because of smoking, but you might have been introduced to smoking by your parents. So like it's not entirely your fault, but it's like partially your fault, so it becomes like a little bit iffy there. And then of course this whole area is about what do people do if they delay their like treatment as well. So that's in Parsons, apparently you don't delay treatment because you go seek help, but people delay treatment all the time. Then the last point was talking about the role of carers. Australia has an interesting policy in that a carer can either be like a family or a friend, and it's if you spend a certain number of hours every week taking care of someone else. And they have something called carers pay, where if you like apply for it, they'll come assess the person you're taking care of. They'll like give some assessment, they'll ask some questions, figure out how much care they need, and then they'll pay you accordingly. So that's like really good for like, let's say, people who have like Asian parents. If they don't want to send the parents off to a nursing home, they want to spend time taking care of them, but they might have to leave their work to do so. So at least they get paid for it. So there are like kind of 3 ways family friends are usually impacted by like a sick one. First is it tends to be like resistance, especially if it's like a chronic diagnosis, like resistance, like you don't have cancer, like sure you don't have cancer. Secondly, restructuring, so trying to reorganize your life based on that diagnosis. So it might be things like trying to make it like a new routine, or even if like you found out, I know your great grandparent had breast cancer, instead of visiting them like once a month, you'd start visiting them once a week. And then consolidation is like when the new rules have been set in stone. And here are just some like positive and negative impacts of caring, which is pretty self-explanatory, but some points there in case you wanted to look at it. All right. I think is that it? Yeah, I think that's it. Let's go into Peter's. Where's your slides?
It should be there. If not, I can share the screen. Yeah. It's in the complete.
I'm just reloading it.
Oh,
I don't know. I don't see it.
it's on my slides. I'll share.
Okay, cool.
All right. So now we're going to move on to prevention and change, which is the other topic of MOM for this week. So changing behavior. So obviously as a doctor, you'll come across patients who might have bad lifestyle or just have bad habits that's affecting and impacting their health life or health in general. Then you'll probably need to try to change the behavior, right, to have a better outcome for the patient. But changing any behavior is very difficult, especially if it is health related. But it is very important for doctors and you guys in the future to help change the behavior of a patient. But it will be really hard. And some patients might really want to change, but they might not actually result in changing. And this could be due to a lot of different things. But addiction, for example, is very hard to just, a lot of people know smoking is bad, but most of them can't stop it without any professional help, right? Because it's very addictive. So it's really hard to change. And hence there's been models developed by a lot of different people to see how we can help with behavior change and how behavior change in general works. So we'll go through some of them. So this, one of the models we have is health action process approach. Now this, like for MOM, a lot of times a lot of questions will be kind of around models and asking, oh, do you know what stage it is, or what would happen, or what stage would this be in? So this is pretty important to know. So this is a two-stage model. The first one is motivation stage. So intent to act is formed through considering, right? So risk of maintaining behavior, positive outcomes of changing behavior, self-efficacy for change. Whereas the second one is volitional change stage. Sorry, I can't pronounce that. This is when you plan for action and self-efficacy to deal with barriers, engage in behavior, and self-efficacy in coping with failure and relapse. So this is just how it looks. It's a really good diagram. You should kind of look through it again later in the future. Now this one, the Prochaska and DiClemente health behavior change. This is really important because I think I saw like 3 or 4 questions on this in every exam. Not every exam, but there's 3 or 4 questions in total, like 4 exams, 5 exams that I did. And I think we had one in our exam as well, if I'm not mistaken. But basically it has 5 stages. Technically 6, if you want to count what the last one, but basically 5 main ones. First one is pre-contemplation, which is the patient is not thinking about change yet. So this is prior to considering about change. And then the second one is contemplation, which is obviously considering or thinking about change. So this is the patient. Third one is preparation. So this is when the patient is starting to make arrangement, plans to change. And the fourth one is action. So this is when they are when the actual change, actual behavior change is underway. Obviously, this doesn't mean that they will succeed, but this is when they're trying to change. And the 5th stage is maintenance. Maintenance. And this is when change is maintained. So after they've changed, they've continued it, right? So if they were to stop smoking, then they haven't smoked for like 2 weeks or so. But there is also a last stage, which I didn't write here, but it's at the end, which is relapse. This is when you kind of go back to your old behavior. So for example, if you were smoking, or a smoker, if a smoker is not worried about him smoking or themselves smoking, then they're in pre-contemplation, right? They're not thinking about change. But then if they're starting to think, oh, I should probably quit smoking someday, that's contemplation, right? They're thinking about it, but they haven't really made any plans yet. Then for preparation, they'll be like, oh, I really should stop smoking. Maybe I should, call the quit line or go to see a doctor. That's preparation. And action is, talking to those people and trying to change, right? Trying to cut down on the amount that you smoke every day, or just trying to stop smoking in general, right? The maintenance is, after 2-3 months, you're still not smoking, right? And then the relapse will be, even though you did change for a little bit, you go back to your old habits, which will be smoking again, right? So it's a really, really big model in medicine and psychology in general. So this is really important to know. But you do need to know there's limitations. The first one is there's fuzzy boundaries between stages, right? So sometimes there could be cases where you're unsure which stage is this person in. And then there's also duration of stages, right? How do you know how long it is, right? And also limited individual variation. Like some people might go from contemplation straight to action, right? It really depends on certain individuals, and they don't account for that. So that's some limitations, but it's a really good model in general. Yeah, so next slide, please. Oh, never mind, I'm doing the slides. All right, attitudes. So attitude is relatively enduring organizations of beliefs, feelings, and behavioral tendencies towards people, objects, or issues. And there's 3 components to it. It's in this order. So CAB, if you want to memorize it. Cognition. So this is beliefs, ideas, thoughts that people have about a matter. Then there's an affect, which is emotions or feelings stimulated by subject matter. Behavioral intentions, which is predispositions to act in a certain way toward an object. All right, so for example, an attitude towards medication. For C, it could be medications make me feel better, right? That's a belief. Disease needs to be treated. That's an idea or belief, and it's worth the money, okay? That's also a belief, right? That's cognition. Then the affect would be, I don't mind, that should be I don't mind taking tablets, right? I worry about the disease more than taking the tablet. That's the emotion, that's the feeling that they have. And then the B would be, they are more likely to adhere to medications, right? Because of the fact that they have these cognition and affect in their minds. So that's just a way you can do it. And in a question, they might ask, like what is like the C for this scenario or something along those lines. So it is pretty important to know roughly what those mean. Now, these are some dimensions and features of attitudes. Dimensions, I don't quite remember being really that important, but you can read through them. Features, a little bit, because you do need to know that attitudes are relatively permanent. So it's really hard to kind of change someone's attitude, which is why a lot of different things, which we'll talk about later, we can kind of like guess what that behavior would be based on attitude, right? And also it's limited to socially significant events or objects. And it is generalizable, and it involves at least some degree of abstraction. My pronunciation is really bad today. Okay. So attitudes can predict behavior, right? But it's not really a straightforward relationship, right? But when we can, the times we can predict behavior from attitude is when we have an attitude and behavior that is just basically in relation to only each other, right? And it's also if it is a social norm, right? If it's a social norm to do something, then it'll be pretty easy to predict the behavior. Also, significant others share the same attitude normally. That's most likely because you live with each other for a long time, you know each other a lot, and if you live with each other for a long time, you probably share a lot of same attitudes. Also, attitudes are really strong and implicit and has developed from personal experiences, a lot of them. So if that is the case, then it can really predict the behavior. Right. So for example, if you have a really racist person, their attitude towards, maybe for example, Asians might be, they're bad, then you can kind of predict the behavior would be very, like they won't be kind to Asians, right? Or whatever race that they're racist to. Right? That's because it's just very strong and implicit, maybe unconscious because it's so strong. And maybe, they just don't have good personal experiences with different races, right? So that's when we can predict behavior, but not always. We need these type of things to happen. And then there's persuasion. So this is really important for you as a doctor, right? There's some people that are naturally good at persuading people, but there's some people that aren't. But in the end, you really should be trying to persuade a lot of the patients. You have to respect their autonomy, obviously. If they decide not to do something, you can't just say, no, you have to do it. But if you know that it's going to have bad impact on their health, you should at least try to persuade them as a doctor. So for example, if you have a smoker who came in because of a heart attack, right, but they're still smoking, right, you should at least persuade them, right? But there's 3 components to it. First one is source. So who sends the message, right? These people need to be credible. It should be an expert, should be trustworthy, likable, similar to the patient, and also in a way attractive. And this doesn't necessarily always mean about the looks, but just maybe the way they say things, right? So it sounds better. Message. So the message that you're trying to send should be based on facts and should be repeated. Fear is also a really good motivator. If you tell the smoker you're going to experience this heart attack again, a lot of them will be like, okay, I probably should think about quitting smoking because heart attacks are a very serious thing, right? That's a fear. And then the audience, so the person listening to you, how open is the patient, right? Prior beliefs and attention, right? If they're not open to change, they probably won't change. It's really hard to take someone who doesn't want to do anything and make them do something, right? So there's also 2 channels by which attitudes can be altered. So the central route, so this is when there's a motivated patient and they listen carefully. So this leads to enduring change. And then there's the peripheral route, which is the patients do not really listen to the message. There's low elaboration and surface level discussion. There's no deep discussion, and only appeals to audience emotions. And hence it will only lead to a temporary attitude change, right? For example, if a person who, as I said, had a heart attack after smoking, if you say, oh, we're going to have another heart attack after, they might feel like, oh, that's pretty scary because I just had a heart attack. But if they weren't open to change, they might be like scared for like the first few days. And then they realize, oh, I've been smoking for a little bit and I don't have a heart attack. I can do it again. Then that will lead to back to the normal attitude or behavior. So that's persuasion. And that's it for Mom. Any questions? If not, I'll just move on to pharmacology.
Prepare yourselves to be terrified with pharmacology. I just share screen just so I can just to control the pace a bit. Where have I put my pharmacology is the question. What I'm just going to do, I'm going to close the tabs I have open and then sorry, computers, I still don't understand how to use them. Let's go. No, not you. It's on the slides, yeah? Okay, pharmacology, here we go. I'll drag this over here. Sorry about this, everyone. Share screen. Pharmacology, 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 where is it? Show all windows. Okay, here we go. I had to click show all windows because I have that many tabs. I'm just gonna make sure no, it's not. This is not the right one. Oh, I'm gonna stop sharing for a second. Pete, stall while I figure. Give me a second. Come on. Oh no. Oh, I think I might not have saved. That's really sad. Not there. Yes, it's here. Okay. I'm going to go to Zoom. I cannot explain to you how scared I just got. Is this the right one? Beautiful. Okay. Sorry about that. Okay. This is probably the most memorizing you're going to do this year, and it's a bit scary. So if you have any questions along the way, just tell me. First slide's going to scare you. Get ready. No, it's not. So first, I'm going to explain to you some definitions and concepts involved in the administration of antibiotics and antivirals, and a little bit of antifungals. So two concepts. I'm actually going to start with the concept on the bottom. When you administer drugs, there's this acronym called MIND-ME that they'd like you to remember. So M stands for microbiology guides therapy wherever possible. In other words, find out what organism it is and then treat the organism. Indications are evidence-based, which means the drugs you use have to be supported by evidence and literature. You can't just make stuff up, give drugs that don't work. You want the narrow spectrum required, because if you give a really large spectrum, you can knock out a lot of flora and it can lead to mutations. So you want something really specific to target a specific microorganism, especially if you know what it is. You want your dosage to be appropriate to the site of where the infection is, the individual, and the type of infection. You want the duration of therapy to be as short as possible for the kind of convenience of the patient. This shares ensure monotherapy in most cases. They kind of want you to do orally wherever possible. Sometimes you don't always have the luxury of knowing which microbiology, which organism is causing the pathology. So then in that case, you'll use empirical treatment where you don't know the causative agent, but you're going to give something a little bit more broad spectrum just because you don't know what's going on and you want to kind of treat it. You can give prophylactic treatment, which is often in susceptible individuals. You give them treatment to make sure they don't get infected. For example, immunocompromised people in the flu, you want to give them the flu shot, or you want to give them some antivirals we'll talk about in a moment just to make sure they don't get the flu. And directed is when you know exactly what the organism is and you treat it exactly. Antibiotics, antivirals, all of this can either be bacteriostatic or bactericidal. Bacteriostatic inhibits growth. In other words, it doesn't kill the bacteria, it just usually targets DNA synthesis, so it can't replicate or produce protein. You would require an effective immune system to treat it. Bactericidal, kill bacteria. An important concept is gram-negative, if you can remember, in their cell wall, have endotoxins. These can cause shock. So if you use a bacterial antibiotic on gram-negative, you can really cause a lot of damage to the patient. But sometimes if there's for example, a infection in the ECF, you don't really have in the cerebrospinal fluid, not ECF, in the cerebrospinal fluid, you don't have many immune cells there. So bacteriostatic, and it's really, really dangerous. So even though it's often gram-negative positive agents, you use bactericidal. But a common rule is if it's gram-negative, bactericidal can cause a lot of damage. Just keep that in mind. That's very examinable. This is when you should start getting a little bit scared, but not too scared. This is kind of the classes of antibiotics that target a cell membrane, cell wall. They can affect the cell membrane, amoxicillin, daptomycin. They can affect DNA synthesis, cell wall, folate synthesis. We'll talk about all these. It's kind of meaningless just as this image, but this image is useful to come back to and look at the end. There's also a couple of mechanisms of antibiotic resistance. You have like those P-glycoproteins, which efflux the antibiotics from the bacteria. The bacteria have channels that kind of throw the antibiotics. Yeah, it's not really what someone else will be talking about this, but yeah. Is there a question? Do we need to memorize those drugs? Oh, just you wait. You need to memorize these drugs. So you might be scared because there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21 drugs to memorize. That is a lot of drugs. And I'm going to be honest with you, I didn't memorize 21 drugs. What does help is you can class these drugs together by the mechanism of action. So instead of just memorizing the name of 21 drugs, what you're going to end up doing is you're going to think, okay, it inhibits the cell wall. I know there's 3 drugs that do that. That's amoxicillin, cephalexin, vancomycin. I know vancomycin sounds like gentamicin, so they're probably the same class, and you'll associate them together. I know metronidazole causes metallic taste in the mouth, so I know what rifampicin causes orange piss, so I know that's used to treat whatever. And these are 2 TB drugs. So you're just going to have to make little connections between these drugs instead of just remembering them all. If it ends in vir, it's a viral therapy. It's often for HIV. I know seltenavir is influenza. So I'm gonna talk you through it, and it will eventually stick. Lots of people use pneumonics. Amphotericin is amphoterrible because it's a really harsh drug. So you will be intimidated. That's probably very reasonable, but you'll be okay. It's not too bad. And they don't ask too many questions about it. We're gonna now, how are we feeling? Are we scared? I'm going to assume you're scared, but you don't have to worry. Cell wall. So we've talked about the cell wall in previous weeks. And what you'll remember is there's gram-positive and gram-negative cells. Gram-positive cells have really thick peptidoglycan layers. They're often targeted by antibiotics that inhibit the synthesis or cross-linking or polymerization of peptidoglycan. And those antibiotics will be very effective here. They're not going to be so effective for gram-negatives, because as you can see, there's only a little bit of peptidoglycan is blocked by walls of lipopolysaccharides. You have does anyone know what this depiction of a membrane, what pathogen this is depicting, what microorganism? Any guesses? If it's a zeal, do we have a guess? TB, yeah, beautiful. So the reason why you know it's TB is it has this mycolic acid in the wall. It has a waxy lipid membrane, And if you give them antibiotics that usually target this peptidoglycan, the wax is just going to go off the wax. It won't be able to penetrate through. Even though it has a little bit of peptidoglycan here, it can't get through all this acid. It can, but it's very limited, so it won't work very well. I tried to use lots of colors, which I haven't done before, but I think it looks pretty good, but maybe it's a bit too much. I liked it. Antibiotics are divided in different classes. And essentially every antibiotic of the same class has a very similar mechanism of action, indication, adverse profile. So really you just need to memorize the class, and kind of sometimes the suffixes will tell you what it is. But beta-lactam is involved in the peptidoglycan synthesis in the cell wall. So the way beta-lactam antibiotics work is they prevent the final cross-linking stage of peptidoglycan synthesis by binding to an enzyme. And if they can't finish the final cross-linking stage, it's not stable, and it'll lead to a weak cell wall and osmotic lysis. Do we know what osmotic lysis is? Can someone quickly chuck in the chat how you think osmotic lysis would work? If you don't have a cell membrane, why does it die? That might be too general, but oh, someone did it, thank you. Yeah, water comes into the cell, exactly. So if you remember, water moves to an area of higher osmolarity. If you don't have a cell membrane, water's going to flush in and lyse. Beta-lactamases are involved in the break, and so yeah, so that's how beta-lactams work. An important nuance to add on this is that beta-lactamases are enzymes that some microbacteria have, and they're involved in penicillin resistance. They work by breaking down these drugs. And in order to combat that, often you give something called clavonic acid, which is an inhibitor, and it's also called augmentin, which you may have heard before. Adverse effect profile, this is probably the highest yield I'm going to tell you today, is that there are allergic reactions to amoxicillin, to these beta-lactam classes. And due to cross-reactivity with other drugs in the beta-lactam classes, such as cephalexin, you should avoid cephalexin in patients with allergies to amoxicillin. Some people get it confused. You might see it differently in other places. That it's wrong if you see it differently. You shouldn't, there is some cross. The reason why it's here and there is there's not actually a ton of evidence for the cross-reactivity, but that's just the way that people do it. So yeah, keep that in mind. Indications, mainly more gram-positive. It might have a little bit of efficacy in gram-negative, but it's going to be limited due to that cell membrane, and also because the peptidoglycan's thick and gram-positive. This is longer than most of the other drugs because amoxicillin is probably the highest yield drug. It's broad spectrum. What does that mean? Any guesses? It means it has an effect on a lot of different types of microorganisms. It's bactericidal, which means it kills the bacteria. And I've mentioned that. If you have a penicillin allergy, often you're going to want to give erythromycin. Do not give cephalexin. Might be a multiple choice about that. Another sort of drug this is a bit of a harder drug. It's a bit more intense. It's called vancomycin. Often it's given in patients who have gram-positive bacteria, and if it's resistant to amoxicillin. So it's a bit heavier than erythromycin, but sometimes it's given as well. And it works by preventing the polymerization and elongation of the polypeptidoglycan chain, which causes that osmotic lysis of bacteria cell. Often in exam questions, they look for key buzzwords that are going to help you know the answer to questions. And a lot of adverse effects are these buzzwords. For vancomycin, please remember red man syndrome. It causes vasodilation, and it affects has ototoxicity and nephrotoxicity. For ototoxicity and nephrotoxicity, I want you to remember vancomycin and associate it with gentamicin. Vancomycin, gentamicin. Think of those, then you will remember the ototoxicity, nephrotoxicity, which is occasionally asked, not as frequently as the red man syndrome is. There's a tuberculosis drug, which is used. I've also colored it to group them in classes. There's a tuberculosis drug called isoniazid, which also inhibits cell wall. It does not affect peptidoglycan, but it prevents glycolic acid synthesis. So TB can replicate. So TB often replicates inside the macrophage, and this is a really good drug because it works inside the macrophage. You can see the glycolic acid works on here. It can cause hepatitis, really important, sonazide hepatitis, and peripheral neuropathy, which is less important. It's bactericidal. It's a heavy drug. We're now going to talk about protein synthesis. This is a beautiful diagram from one of the lectures. I've been coughing for 4 weeks. It's a beautiful diagram from one of the lectures, and it just shows you the different ways drugs can interact with the ribosome complex. Some of them reversibly bind, some of them irreversibly bind, and they can bind to the 30S portion or the 50S portion. Does anyone know what the, if a bacteria is 70S, does anyone know what a human is? That bacterial formation. It's not important, but maybe you know. It's 80S. Oh, did someone get it? Yeah, nice. Good job, Jess. So chloramphenicol isn't a drug that's really used anymore, but because of this only slide, people think involve it in notes. I involved it in my notes, but because it really has a really high toxicity effect, it's not really used, and it can cause great baby syndrome. I'll talk about these drugs actually here. I'm trying not to intimidate you too much with these tables. I'm trying to flip between. Erythromycin, really important drug if there's a penicillin allergy. It can be bacteriostatic or bactericidal depending on concentration, or if it's involved in ribosome replication. So most of these drugs are going to be bacteriostatic, with the exception of gentamicin, which is a really tough drug, really toxic. It reversibly binds to the 50S subunit. There is some hypersensitivity, not really, and it can affect the heart. Clarithromycin, these are derivatives. If my internet goes bad, just let me know. I can repeat stuff if it cuts out. Clarithromycin these are derivatives. One's a synthetic derivative of the other. It's also a macrolide, and it's this all the same as erythromycin. Chloramphenicol, I put it, it's not really used anymore, but just put it there. It's bacteriostatic, it's quite toxic, so it's limited. It also binds reversibly to 50S subunit and inhibits the peptidyl transferase activity, which is when the tRNA, when it's loaded onto the tRNA, the codon, no, the amino acid is loaded, and then it transfers it, like when it grows, the polypeptide chains growing through the enzyme peptidyl transferase because it transfers the amino acid here. Not important. That is really important. Gray baby syndrome, keyword. It'd be kind of mean if they asked you that because it's not really used much. Gentamicin is a tough drug. It's in gram-negative and Staph aureus. That's high yield. Try to remember that. It's not effective for very effective for anaerobics, I think. Aerobic stuff. It binds reversibly as well to 30S subunit that causes misreading. It's aminoglycoside, if you remember. Don't worry, not there. You don't need to remember nephrotoxicity and otoxicity. You should remember. What other drug causes nephrotoxicity and ototoxicity? Starts with a V. Vancomycin. Thank you, Jess. Good job. And do you know what the adverse effect of vancomycin should remember is? Yeah, exactly. Think of a red van, red man. Great job. Doxycycline, you've probably heard of this, is my favorite drug. It's very well. Gram positive and gram can be used. Gram positive, gram negative. You might know it can be used for acne, can be used in malaria. It's bacteriostatic activity. These adverse effects will have been in exams, seen them. Can't use them in children, can cause teeth discoloration of growth. That means in pregnancy, actually, I might add that in because I'll add that in. If the fetus is growing, you also don't want it there. So it's also not great for pregnancy. Lying down, it may burn a hole in the esophagus. It can be hepatotoxic to the liver and cause photosensitivity. So a lot of malaria prophylaxis, people get photosensitivity. Binds reverse with 30S and interferes with the aminoacyl tRNA and acceptoside ribosome. Let me just confirm that pregnancy thing because that's really important. It actually says it's okay in pregnancy, but there was an exam question that said it wasn't, and I think people brought that up with faculty.
There was
So,
definitely an exam question on that, David.
yeah. Do you remember what the answer was? I remember the way I argued it, I think.
I just remember it being controversial.
Yeah. Their reasoning was you can't use it in children are schooling, and so you can't give it to pregnant women because the child is growing. I just don't think there's any evidence of that. So I'm looking at the FDA here. I'm gonna on this is really important. Very high. I'm looking at the FDA, and it says that there's no controlled studies. It's unlikely to pose a substantial tetragenic risk. They just don't know, it looks like. Yeah, they don't know. So it'd be really mean if they asked it. I don't think they'll ask it because we gave them trouble about it. But yeah, remember the children, the bones, the teeth, discoloration, growth, hepatotoxicity, photosensitivity, and this one just scared me, so that's why it resonated with me, but it's less high. Next, we're going to talk about nucleic acid synthesis. So these are drugs. Oh my God. These are drugs that are involved in inhibiting the synthesis. Are these going to be bacteriostatic or bactericidal, do you reckon? Have a guess. It's a tough one. Actually, bactericidal. I actually thought it'd be bacteriostatic. Let's have a look. It depends. So if you're inhibiting a drug microorganism from replicating, that's probably called bacteriostatic because you're not inducing the death of the microorganism, but you're not allowing it to proliferate. It really depends which proteins can't be made. But these are often dose dependent as well. And these are tough drugs. These are all hard drugs. Rifampicin is a TB drug. What was the other TB drug? It starts with an I. Was isoniazid? Does anyone remember anything about isoniazid? Can cause. I gave you a clue there because I knew it would be a hard question. What's an adverse effect of isoniazid to do with the liver? Can cause hepatitis. Rifampicin is also, and rifampicin and isoniazid are often given together. You should know this drug. An adverse effect of rifampicin is, where is it? Your bodily secretions may turn orange and red, so it can be orange. So I think of it as pissing, piss, orange, red, tears, pissing. Can also cause hepatotoxicity. It interferes with the RNA polymerase. Yeah, it also can work on gram-positive. So isoniazid is mainly just TB. This one is TB and some gram-positive as well. It's pretty toxic, this. Next one we're going to do is metronidazole. A side effect of metronidazole is its metallic tasting. You know that because it has the word met in the name. It interferes with alcohol metabolism as well, so you shouldn't take with alcohol. This is my favorite. When in doubt, I say this drug in second year for all the parasitic stuff. So all protozoal effects. It has a good anti-protozoal effects, which means in the exam when David sees this, he's going to circle metronidazole. It works on anaerobic drugs, and they can either be gram-positive or gram-negative. And it prevents nucleic acid synthesis. Finally, ciprofloxacin, fluoroquinolone is my favorite class. I think this is really pretty. It inhibits two enzymes. Gram-negative, it determines which enzyme it inhibits. So gram-negative is mostly going to inhibit topoisomerase 2, gram-positive mostly topoisomerase 4. A bit of a stretch. Does anyone remember what topoisomerase does? Exactly, it unwinds DNA. So DNA actually we don't get taught about how much of a helical like stretching. There's a lot of stress on it when it twists. So topiacides kind of does that like superhelical function. It makes it a little bit more relaxed. So if you don't have that, it causes a lot of strain on the cell, and there's often mistakes. Adverse effects: cartilage, tendon damage, phototoxicity, bone or joint damage. This is a mean drug to ask you, but you should know that's a nucleic acid synthesis. Bactericidal indications due to it's not really important, but it's true. This drug is really high yield, and they don't mention it much, which is a shame. Do you agree, other people? Yeah. Important to know, trimethoprim by itself, bacteriostatic. With sulfonamides, it is bactericidal. They are folate antagonists. You can see in this image, they put folate antagonist part of nucleic acid synthesis. Folic acid is important in synthesis, but yeah, I just put it separately. It's a folate antagonist, a synergistic combination of folic antagonists. It blocks purine production and nucleic acid synthesis, can cause hyperkalemia and nephrotoxicity. What other two drugs can cause nephrotoxicity that we've spoken about? One causes red man. So they were vancomycin, and what was the other one? Gentamicin, beautiful. I've written adverse effects of hypokalemia and nephrotoxicity. Can you think of what another one I've forgotten is? I'd be really impressed if you did. We talked about it last week. So I'm just gonna, can you think of the other adverse effect I've forgotten? During pregnancy. Folate, you'll do this in an ICL. Folate is necessary for the fetal development and can cause spinal bifida, because involved in neural tube formation, which is why that occurs in the first trimester. Indications are sometimes MRSA, travel diarrhea. They won't ask you more about indications. They do ask a lot about this drug. They'll ask which drug is a folate metabolism disruption. You have to say these. It's bacteria. Yeah, we said that. Antivirals now. Info. Antivirals. Actually, I'll ask you this. I've already showed you the slide, but why are antivirals not spectrum? Any guesses? What are antivirals targeting? Hard question. They're usually pretty specific proteins. So they're not going to have a lot of cross-reactivity, and you don't want them to be broad spectrum because there's going to be a lot of resistance because viruses replicate really quickly. So you've got a lot of resistance if it's broad spectrum, and it's have very specific, often like target particular enzyme that has a particular configuration, and it doesn't really have cross-reactivity. Whereas lots of bacteria have peptidoglycan in their cell membranes. That's a really broad spectrum. It's only virustatic. What does virustatic mean? So it doesn't kill the virus, it just neutralizes them. So you do need a good host immune system to combat it. And resistance is a problem, as we've discussed. We're going to talk about a bit about HIV. If you don't remember anything, you can zone out after say this. You're best to use 2 to 3 drugs from multiple classes to prevent resistance. This is kind of the various ways. Let's explain how HIV works. So HIV is going to bind to the CD4 molecules and deposit a viral RNA. The viral RNA is then going to be integrated in the host DNA. So this is why central dogma is not true, by the way, because in central dogma, you learn transcription, what was it? Transcription, translation, post-modification. This one actually goes from translation to transcription. It kind of goes backwards. And so it's a reverse transcriptase uses it into the viral RNA to that can be incorporated into the host cell. then it's going to be produce some protein, basically the buds of the cell, and proteases are involved in activating those buds so they can go out. So you can use a variety of drugs to target. Either you can target the reverse transcriptase, which gets the viral RNA to viral DNA, or you can target the integrase, which takes that viral DNA and puts it into the host cell. Obviously, you can't put viral RNA into a host cell. That's why it does this step. Or you can target the proteases, which are involved in the release, budding, or activation of the HIV. Your treatment, HIV suppresses viral load. So you want to suppress viral load, and you want to do this to prevent transmission, maintain immune function, prevent HIV symptoms, and decrease mortality. This is it's not cool, it's sad, but this is how HIV affects CD4 count, and these are all the conditions that are associated with it. So you want to reduce viral load so you have a higher CD4 count and you don't get these symptoms. And decrease mortality, and drugs can be what we've spoken about before. And how many do you use for resistance about? Have a guess, have a gander. 2 to 3 drugs. Ash, thanks, Ash. I keep saying it just before you guys write it in. So if I do say it, just write it even if I tell the answer afterwards, because I should wait for longer. Influenza. You guys told me you knew about this last week. Do you know what drug the name of the antiviral used here? Yeah, okay, it's oseltamivir. So we'll talk about oseltamivir over here. And I made a mistake. I hate making mistakes. Sorry, I should correct this afterwards, but I'm going to correct it now. Okay. So what does oseltamivir, is it involved in the release or in the entry of the viral particle? Neuraminidase release or entry? Yep, it's release. And do you know what's the name of the protein involved in entry? Yes, great job. Hemagglutinin. Hemagglutinin has more varieties than neuraminidase, I think, so that's why they don't have as effective treatments. I think there's less types of neuraminidase. As you can see here, oseltamivir is a neuraminidase inhibitor. It binds here, and what it does is it prevents the ability to cleave sialic acid, which means it could be released. For the virion to be released, it needs to cleave the sialic acid receptor. It's just held down. Yeah, neuraminidase is a cleaving. That's what it does. It cleaves. Some HIV. Pharmacoenhance increases the level of protease inhibitors. It's going to work here. It's going to inhibit proteases. It's going to affect the packaging release and the activation of the HIV. It's part of highly active antiretroviral therapy. It has horrible GI effects. Tenofovir is also, it inhibits viral polymerase, and it terminates DNA chain after incorporation into viral DNA. It has GI effects, and it's used in prophylaxis and treatment of HIV, part of PrEP. I'm going to ask you a question. Where do you think tenofovir, I'm going to make sure I'm right. Where do you think tenofovir, what sort of HIV drug is it? Does that make sense? So we talked about reverse transcriptase inhibitors. What one do you think it is? I think the answer's on the slide if I show it. So have a guess and then I'll show you. And we know tenofovir is used to inhibit viral polymerase. So what are 2 options? It's either going to be an integrase or reverse transcriptase inhibitor. If it's inhibiting viral polymerase, is that more likely to be reverse transcriptase inhibitor or integrase? I dragged the point on a bit. So because it's a polymerase, it's going to make the DNA. If it's inhibiting that, it's going to be a reverse transcriptase inhibitor rather than an integrase, which is all incorporation into the DNA. I hope that I asked you the question so that you know what's important and also so that you understand the concepts. Acyclovir is used for herpes 1 and 2, and also varicella zoster, which is also herpes virus. And it works as a guanine analog that inhibits DNA synthesis. So it works only in DNA viruses. That would be a good, if I wrote a multiple choice question, I'd say I'd give an RNA virus and say acyclovir won't be effective for, or give only RNA viruses and say acyclovir will be effective for and only DNA virus. Oseltamivir we've talked about, it's A and B. Is there such thing as influenza C? Yes, there is. After metabolized, it binds to polymerase, prevents release from cells. We talked about it. Interferon alpha is a why are lock causing GI adverse effects? It's a good question. I don't know. When I say GI effects as well, it's real stuff. Like it's sometimes it's really harsh. I don't know why antivirals. Why do any of the know?
No, sorry.
Okay, I'm gonna search it up now. I couldn't tell you. I'll get back to you on that because I'm interested myself. They won't ask you about this in adverse effects. I had to search for this stuff, but it's a good question. Because I told you it has a, why would, you know why antibiotics would have severe GI effects? Because antibiotics will target normal flora as well. And that can cause a lot of no, I can't find it. Sorry. So the reason why antibiotics cause GI effects is they target normal flora in the stomach, which is involved in nutrient extraction and vitamins and like normal functioning of the gut. So that's why that has a lot of GI effects. But I told you that this has a really limited range of action. Sorry, spectrum of action. So it's a good question. I wish I knew the answer. Interferon alpha stimulates immune response and interferes with viral RNA, headache, fever, chills, retinopathy, dose dependent. There's a lot associated with interferon alpha. It's used in cancer and Hep B and C. Stimulates immune response. Almost done. Last slide, I think. Second last slide. Low yield. But remember the names and you'll know. Amphotericin, amphotericin. It is a very harsh drug. And it's really like hurts to have. Not hurts out, like it's unpleasant. Does anyone know what a gostrol is? What does it sound like? Super high yield. It is a cholesterol. So it's a cholesterol that is unique to the fungi, and it is targeted by drugs because of that reason. So drugs such as fluconazole, which you're going to remember, meconazole, fluconazole, I think it's cute, it doesn't help, but that is used to target a gostrol. High yield probably will be asked. What does it look like amphotericin is going to target? I'll just show you. Fluconazole, azole antifungal. It's usually for minor infections. How do you remember which is minor? Severe. Amphotericin, amphoterrible. So it's severe. Harsh side effects and severe infections. Fluconazole more minor. It inhibits the enzyme that converts lanosterol into ergosterol. This is membrane permeability and causes cell death. Because if you remember, cholesterol is used to maintain the membrane fluidity in human cells, and I think it would be similar here. It's pretty well tolerated. Amphotericin works by binding to ergosterol and creating pores to alter cell permeability. And yeah, we talked about smodoclisis. Severe systemic fungal infections, Aspergillus candidus, really bad stuff. It's not very well tolerated at all. That's all for me. I am not sure if we have other presenters today. Do we have other presenters today?
I have some for microbiome.
You got some micro ready?
Yeah.
Yes. We'll throw it to Andrew. If you have any, are there any questions? Sorry. Lots of people use Anki to memorize this. I didn't.
I don't have sharing enabled right now though.
Oh, let me make you.
So unless you can go into like the week 11 stuff.
I just make you co-host, control your speed. Yeah, how to learn all the drug names. Some people use Anki. I read it a lot. That helped. But yeah, I don't know. Second years, do you have advice to learn drug names?
I don't know. A lot of people just like come up with like funny names and like weird connections and stuff like that. And yeah, it's like repetition, I think. Yeah, I think that's about it, to be honest.
Repetition, like on the bus, on the train.
Like metronidazole, you get like a metallic taste as a side effect, and then people are like, oh yeah, metro train, it's metallic, so stuff like that. Yeah, a lot of different stuff. Anyways, microbiome. So looking at antimicrobial resistance today. To start us off, antimicrobial resistance, fairly self-explanatory, but it's a microorganism's ability to resist bactericides, fungicidals, virucidal, or parasiticidal effects of a chemotherapeutic agent. So that's stuff like antibiotics, antivirals, antifungals, etc. Antimicrobials can be one of two things. They can be static or cidal. So if they're bacteriostatic, that means they inhibit the growth of the microorganism and it stops it from further growing and multiplying, but it won't kill it. If you have something that's bactericidal, that means it will directly kill the organisms. And they also have something called selective toxicity, which is quite important. So obviously, if you have a antibiotic, you want it to target things unique to the microbe, so your own body isn't targeted and it's not harmed. So 5 major targets you've already sort of covered with the pharmacology stuff is the cell wall synthesis, your protein synthesis, your nucleic acid synthesis, certain metabolic pathways, and your cell membrane function. Resistance to antibiotics, it can either be innate or it can be acquired. So something that's acquired would be alteration of your target site for the drug, access to your target site if it's changed, so you have altered uptake of the antibiotic into the cell perhaps, modification and destruction of antimicrobial agents, and active efflux. So we'll go through that a bit more in a little bit. If you have innate resistance, then these bacteria are just naturally impermeable to an antibiotic. So if you take Mycobacterium tuberculosis, it's a unique bacteria when you compare it to all the other ones you normally look at, because it has like waxy lipid layer and it has mycolic acid in its membrane. So that actually prevents antibiotics like penicillin from accessing the peptidoglycan, which the penicillin normally destroys. And you have a little diagram on the right there, which just shows you all of these waxy layers and the mycolic acids that sort of prevent the penicillin from getting to the peptidoglycan. So this is innate resistance because the bacteria has always had this, and it's just part of the bacteria itself. So bacteria can also acquire antibiotic resistance. So they weren't resistant before, but they become resistant after they acquire a natural mutation, or perhaps they acquire genes that make them resistant. So one of these is the altered access alteration of the target site. So for example, they can just have a random mutation and then this changes perhaps amino acid sequence or one of the enzymes that you're targeting. And then that mutation could change the conformation of the targeted enzyme so the agent cannot reach the site, or perhaps it can't attach to the site. You can also have modification destruction of the antibiotics. So this produces an enzyme, they could produce an enzyme that modifies or destroys the antibiotic so it doesn't work anymore. And this will be like acquired. So it might be they take up some DNA from outside. We'll go through this a bit more later, so I won't go into detail. You can also have active efflux, which is where the microbe has a pump on its cell membrane, and that actively pumps out the antibiotic that has come into its cell membrane or its cytoplasm. So if you have modification and destruction or efflux, these can be acquired through something called horizontal gene transfer. So that means it's not inherited. It wasn't from binary fission. They've actually gotten DNA from the environment. So these are just some general methods they can kind of thwart antibiotics and become resistant. So just keep them in your mind generally, but you don't need to know them in very specific details. So what's horizontal gene transfer? You can have three ways of horizontal gene transfer, which is just getting DNA from your environment rather than binary fission. So the first one is just transformation. That's just uptake of external DNA. So that might be DNA, that's literally just DNA lying around in the environment. It might be from another bacteria that somehow left it there. Maybe some bacteria just got killed and it's just like exploded or something and it's left all of its DNA in the environment. Other bacteria surrounding it can take up the external DNA. There's something called conjugation, which is DNA between two bacteria via a sex pilus. So that's what's depicted in the little diagram there. You don't need to know the process in much detail, just know vaguely how it happens. So you have a little pilus, which is like a cytoplasmic extension that connects the two bacteria, and then it will replicate the DNA and transfer it to the other bacteria. And then the third thing is transduction, which is sort of interesting. It's via bacteriophage. That just means virus. Bacteriophage is just a virus. So this virus will have DNA with it. And when a virus infects a bacteria, it will inject all of its DNA into it. So perhaps you have a faulty virus. It injects its DNA into the bacteria, but it doesn't kill the bacteria. And it just happens to have some new DNA with it that may contain, I don't know, something for an enzyme, something like that. Also don't need to know this process very well, but these are just some of the ways that horizontal gene transfer can occur. So we'll talk a little bit about plasmids. As you can see in the diagram on the right, what they transfer is the plasmid itself in conjugation. So plasmids are circular self-replicating double-stranded DNA molecules that are separate to the host chromosome. So if you see in step 1 of the diagram, you see you have your bacterial chromosome, which is just a bunch of loops, is just a big loop of DNA. And then you have that more circular looking bright pink DNA plasmid. So that's separate to the chromosome itself. They self-replicate, the circular, double-stranded, and these can be transferred via conjugation. So plasmids can contain many genes. It might be metabolic enzymes, virulence genes, but what's important is they can contain resistance genes as well. And then these ones are known as resistance plasmids or R plasmids. So just for example, R100 is a plasmid known to contain many resistant genes. You don't need to remember the name, but it's just an example. Something else is transposons. So these are quite odd things. You also don't need to know much detail about this. I don't remember this coming up much at all in any questions, but it's something they mentioned in a lecture and it's pretty cool. So these are called jumping genes. So these are regions of DNA that actually encode things that move them. So these genes can move themselves from plasmid to plasmid, or plasmid to chromosome, or chromosome to plasmid, etc., so on. So the problem is that they can often contain resistant genes and that will further propagate them. So one bacteria might get a plasmid that has jumping genes, and then these jumping genes could jump to the chromosomes of the bacterial host. It might jump to other plasmids. These plasmids may then be distributed to other bacteria, etc. So you can just see how they spread.
So Andrew.
Yeah.
I think someone had a question in the chat.
Okay. Why is it horizontal? That's a good question. So sometimes they will refer to vertical and horizontal. So vertical is sort of generation through generation. So it's from like mitosis or binary fission, right? That's what's considered vertical. I guess if you had to visualize it, it might be generation of, if you just think of families, it might be generation after generation after generation. And that can be, I guess, visualized as vertical. Whereas if you obtain it from your environment, it's sort of like from other organisms that are unrelated. And that's like also the same generation, and that's kind of more horizontal. Does that kind of make sense? So vertical just kind of refers to like being passed down, I guess, and from being inherited, from generations. Whereas horizontal is kind of just the same more of like the same generation or from the environment, stuff like that. That's the general gist of it. Hope that makes sense. Okay. If you have any more questions, let me know. Non-genetic basis of resistance. So sometimes you don't actually get resistance from the genetics. Sometimes it can just be like physical things. So one example is bacteria can be walled off within abscesses. So these are basically like little cavities of pus that are created in an infection. So in these little basically capsules of pus, what can happen is that the drug won't penetrate effectively, and you'll need surgical drainage and antibiotics. Oh, sorry, I think that little second dot point shouldn't be there. I was trying to format and obviously didn't work. So just ignore that little second dot point that's been indented. Sorry about that. Another thing that can happen is the bacteria can remain dormant in the tissue for many years. So for example, if you have Mycobacterium tuberculosis, these are quite slow growing organisms, and they'll come up again and again. They'll mention that to you. So if Mycobacterium tuberculosis, they can become dormant, and when they're dormant, they won't actually take up any antibiotics. So for example, when you're treating Mycobacterium tuberculosis or tuberculosis, your treatment will actually have to last for a long time to sort of match their slow growth, and to make sure you kill all the tuberculosis. Another thing that's very niche is that some bacteria can actually lose their cell wall and just survive as a protoplasm. So they only have their cytoplasm. In this case, you can imagine they'd be insensitive to cell wall active drugs. Also, if you have a foreign body, such as surgical implants or catheters, what can happen is that bacteria can grow on these to make a sort of film. It's called a biofilm. And when you have a surface of biofilm, it makes it quite hard for the antibiotics to penetrate the surface of the biofilms and to get to the rest of the bacteria. So that's also something. Biofilm is something you hear that comes up a lot. The slide isn't too important, but just highlights some of the different ways that are possible for non-genetic basis of resistance. Okay, causes. So what causes antibiotic resistance? You probably already know some of this just from general knowledge or perhaps biology in high school. So sometimes you can have overuse in medicine, agriculture, and veterinary practice. This might be due to consumer demand, for example, the patient wanting antibiotics, or medical tourism. So if you go overseas for medical treatment, in some countries, their regulations will be a bit more lax. You can get antibiotics more easily, stuff like that, and you can maybe take them back. Or sometimes in agriculture, they'll feed antibiotics to the animals to prevent the animals from getting ill. This is just to save them money so that, obviously the animals don't get sick, they don't die, so they have more livestock. But however, if you use antibiotics too much, it is a selection pressure. So that means only your resistant microbes will survive, and these microbes that are remaining will proliferate. And so if you don't use your antibiotics properly, these resistant microbes will survive and proliferate, and you get more and more resistant microbes. So for example, incorrect use in medicine can be due to the wrong choice of antibiotics. For example, if you don't use the right antibiotic for the infection, you'll end up killing other irrelevant microbes, and these microbes might become resistant. So that's what happens if you have the wrong choice. If you have the wrong duration or dose, that might not kill all of the microbes, and you have microbes that survive. Or if you have unnecessary overuse, Sometimes this can happen because the patients pressure you. For example, if they have a cold, they just want antibiotics because they think they'll make them better. Obviously, antibiotics won't do anything in a viral infection. However, the patient just wants them. And sometimes it's easy to give in to the patients and just to give them what they want, and they will just feel better from placebo as well. But obviously, you don't want to do this because it will lead to antibiotic resistance. So never prescribe antibiotics for a viral infection, even though it might be hard. Not too important once again, but just some examples of resistant bacteria. You have MRSA, which is methicillin-resistant Staphylococcus aureus. And now you also have vancomycin-resistant Staphylococcus aureus. So MRSAs are quite often hospital-acquired. You'll often find that resistant bacteria are common in hospitals because you use antibiotics so commonly in hospitals. Very common sense, I suppose. But MRSAs are hard to treat. And often the only way to treat them is to use vancomycin, which is quite a strong antibiotic. But even now you have vancomycin-resistant Staphylococcus aureus, and there's not too much you can do there. And then you also have vancomycin-resistant enterococci. These also thrive well in hospitals. The thing about enterococci is that they're actually part of the normal flora. So a patient in the hospital could be colonized with VRA without an infection. But for example, if it spreads to someone else, it could lead to UTIs and infections. And then another example is multiple drug-resistant gram-negative rods. So these are becoming increasingly problematic. They're more of a recent complication, I believe. So many gram-negative bacteria that were once just normal flora that didn't have any resistance have now acquired resistance genes. So one of these bacteria include Acinetobacter baumannii, and it includes a range of organisms. One classification is ESBL, which is extended spectrum beta-lactamase organisms. And these, so penicillins, things like penicillins, cephalosporins, chemically are beta-lactams. So if you have beta-lactamase, lactamase is an enzyme. If you have beta-lactamases, these will destroy the cephalosporins and penicillins. Another is NDM1, which was named after a strain in New Delhi. These bacteria are resistant to carbapenems and they spread quickly through horizontal gene transfer. So what's been found is actually that NDM1 has been spread to many other gram-negative bacteria through horizontal gene transfer. And so if they're in your bacteria, in your microbiota, if you get colonized by them, even though it's not an infection, because some of these can be part of your normal flora, they can make superbugs out of your own microbiota, which is not great because if you do ever get sick or if you do ever get an infection, it can become a problem. A quick note on prevention, obvious things such as hand hygiene, public education about antibiotic use, hand washing, that sort of stuff, and vaccinations for preventable diseases, so you don't have to use antibiotics. You can also track resistance patterns around the world to see where these resistant strains are going around the world. Better use of antibiotics is important, and you might get a workshop on this, I believe. So you always want to use the narrowest spectrum needed, the shortest duration that's necessary, and you don't use it for viral infections. That will be something they emphasize a lot. And something else is just developing new antibiotics and diagnostic tests. But otherwise, not too much of a high yield section, but just know it generally and you'll be fine. And yeah, that's it, I believe. So thank you.